Welcome to This Explainer. We're diving straight into a series of high-yield clinical puzzles focusing on surgical endocrinology and neck masses. We're going to tackle these MCQs back-to-back, exploring specific presentations, critical management steps, and those absolute must-know exam pearls without any fluff. Let's jump right in.
Section 1. Parathyroid and Adrenal Clinical Presentations.
All right, imagine you're on rounds. A middle-aged male is found to have a 2 by 2 centimeter mass in the right adrenal gland. Now, this was just found during a routine checkup, a classic incidentaloma. Your options for the initial workup are a 24-hour dexamethasone suppression test, urinary catecholamine levels, plasma aldosterone levels, a biopsy of the mass, or an MRI. So what should absolutely not be performed initially?
The answer here is firmly option D. Biopsy of the mass is strictly contraindicated. Why? Well, an adrenal incidentaloma must literally never undergo a percutaneous needle biopsy during its initial workup. If you go in and biopsy this thing before ruling out a pheochromocytoma with biochemical testing first, you carry an extreme and frankly fatal risk of triggering a massive catecholamine surge. It's a huge clinical pitfall, so always keep that in mind.
Section 2. Zollinger-Ellison Systemic Presentation.
Moving down the anatomical pathway, here's a classic, kind of complex symptom cluster. A patient presents with severe acid reflux and diarrhea. When you do an endoscopy, you see severe esophagitis and multiple duodenal ulcers extending way distally. Plus, lab analysis shows pernicious anemia. Think about how these puzzle pieces fit together. Severe GERD, diarrhea, distal ulcers, and anemia. What's the most likely diagnosis?
The correct diagnosis is Zollinger-Ellison syndrome, or ZES. Now, what's really interesting about this slide is the why behind the clinical picture. ZES is driven by an autonomous gastrin-secreting neuroendocrine tumor. This gastrinoma creates an enormous, massive gastric acid output. That acid literally overwhelms the duodenum and inactivates pancreatic lipases, which completely explains that severe diarrhea. And incredibly, this extreme acidity directly destroys intrinsic factor vitamin B12 complexes, which is exactly why you see that pernicious anemia. It's all connected.
So how do we actually manage this? Interestingly, your immediate priority isn't surgery, it's pharmacological control. Step 1 is high-dose proton pump inhibitor therapy. You have to stabilize and heal those mucosal ulcerations first. Step 2 is biochemical confirmation, where you're looking for a markedly elevated fasting serum gastrin level, typically greater than 1,000 picograms per milliliter. And then finally, step 3 is localization. We use an ocreotide scan to physically map out where that primary gastrinoma is actually hiding. Section 3. Thyroid nodules and thyroid cancers.
Let's transition to the neck and look at this next diagnostic query. A middle-aged female presents with a solitary thyroid swelling. Really key in on that word solitary. What is the best initial investigation here? Are we looking at an ultrasound scan, CT, MRI, FNAC, or an isotope scan?
The gold standard, single most critical and cost-effective test is option D, fine needle aspiration cytology, or FNAC. FNAC gives you direct cytological classification using the standard Bethesda system. This grading is absolutely crucial because it maps the relative risk of malignancy and directly guides the scalpel. To put that into perspective, a diagnostic lobectomy is explicitly indicated the moment FNAC comes back as a Bethesda 4 follicular neoplasm.
All right, let's escalate the clinical stakes a bit. What if a patient has an insidiously growing unilateral thyroid swelling, but this time you also feel palpable, firm regional cervical lymph nodes right along the internal jugular chain? Given that regional spread, what would be your clinical diagnosis?
Those palpable nodes are the classic fingerprint of papillary carcinoma of the thyroid. You see, papillary carcinoma has a really strong affinity for early lymphatic dissemination. That's why it frequently shows up with palpable lateral cervical lymph node metastases. On the flip side, you have follicular carcinoma, which spreads predominantly via hematogenous routes. Basically, it travels through the blood to distant sites like the bones or the lungs, rather than local lymph nodes.
Now, let's test your pharmacological safety knowledge with a special population. A young patient in her 3rd trimester is found to have hyperthyroidism, specifically Graves' disease. What's the best treatment option for her? Total thyroidectomy, propylthiouracil, methimazole, radioiodine, or a subtotal thyroidectomy?
The answer here is methimazole. So the crucial point is understanding the trimester pivot. Antithyroid drug selection is strictly dictated by the trimester you're in.
In the first trimester, propylthiouracil, or PTU, is preferred because it avoids the risk of methimazole-induced embryopathy. But, and this is big, once you hit the second and third trimesters, you must shift to methimazole. Why? Because prolonged PTU administration actually carries a black box warning for severe maternal hepatotoxicity or liver failure.
Section 4. Postoperative thyroid complications. Okay, let's shift to the high-stakes post-operative recovery room. This is a genuinely frightening, time-sensitive clinical emergency. A 36-year-old female complains of new-onset, progressive shortness of breath just 2 hours after a subtotal thyroidectomy. What is the most likely cause? The answer is an acute tension hematoma. Let's contrast the two main suspects here. A tension hematoma typically develops within 2 to 6 hours post-op, often from a slip ligature. As blood accumulates, it compresses the trachea and triggers respiratory acidosis. Now contrast that timeline with tracheomalacia. Tracheomalacia presents almost immediately upon extubation in the OR, and it's caused by structurally weakened ischemic tracheocartilage just collapsing inward. So that 2-hour mark, it points straight to a hematoma. When a tension hematoma happens, you need to know this airway emergency protocol by heart. Listen, systemic buffers won't fix a mechanical block. Step 1 is immediate bedside wound opening. You literally have to rip open the skin, subcutaneous layers, and deep strap muscle stitches right there at the bedside to evacuate the clot and decompress that trachea. Only after you stabilize the airway via orotracheal intubation do you move to step 4, which is a formal exploration back in the operating theater.
Section 5. Congenital midline neck masses.
Let's wrap up our clinical journey with pediatric and developmental presentations. Consider this physical exam finding. A patient presents with a non-tender midline neck swelling. Crucially, you can move the swelling freely side to side horizontally, but it is completely fixed against vertical up and down movement. What's the diagnosis? That exam finding is the textbook presentation of a thyroglossal duct cyst, a structural embryological remnant tract. Because this cyst is anchored directly to the hyoid bone and the base of the tongue, it has a totally pathognomonic mobilization sign. It will dart upward dynamically when the patient protrudes their tongue or swallows. The definitive treatment for this is the cyst-strunk procedure, and that means radical excision of the cyst capsule along with full clearance of the central body of the hyoid bone to prevent recurrence. And this brilliantly illustrates exactly where these cysts actually pop up. While they can manifest anywhere along the embryonic tract, a massive 65% of cases present in the subhyoid location, right in the midline between the hyoid bone and the upper thyroid isthmus. Another 20% are suprahyoid and 15% are juxtahyoid. So to put that into perspective, if you see a midline mass, that subhyoid space is always going to be your prime suspect zone.
We've covered some incredible ground today, from absolute contraindications in adrenal masses to the terrifying mechanical realities of postoperative neck hematomas. The clinical clues are always right there in the presentation, just waiting for you to piece them together like a giant puzzle. So, with these high-yield blueprints now fresh in your mind, are you ready to spot the hidden surgical emergency before it strikes on the wards? Keep observing, keep connecting the dots, and I'll catch you in the next explainer.